Talk a little bit about hypogonadism and who should be treated for hypogonadism. That's particularly most important for the men in the room. We're going to talk about prostate cancer and when you should be treated or checked for prostate cancer. And then I've also got some stuff in here about BPH and some of the new things about BPH treatment too. So probably if I see you get up and go to the bathroom, I'll pull you aside and we'll talk a little bit more in depth about BPH. So the definition of hypogonadism, so who is hypogonadal or who has a low testosterone? And most of the time when we see guys, most of the guys that are in the room that have gray hair or no hair like me, that's from just primary testicular failure, and it's just as we get older we go into andropause. It can be congenital, there's some things that happen, but most of the time it's just due to aging. It's due to disease processes. Obesity is the most probably common cause of this, and then some of the medications that we take will cause it too. So the influence of testosterone, it's basically virilism. If you look at a guy and you wonder why he looks the way he does, it's because of testosterone. So women don't have it, and if you take a male that before puberty and castrate them, they'll look much like a woman. So some of the signs and the symptoms of hypogonadism, there's a whole list of them. If you guys go on the internet and you type in hypogonadism, you can almost be assured that you will that it will tell you need to go see your doctor to get put on testosterone. And we'll talk a little bit about why the market's geared towards that in a little bit. But the biggest indicator of somebody who needs to be treated for low testosterone is actually the decrease in sexual desire or libido. So it's not erectile dysfunction, that's not from testosterone, but the decrease in desire to have sex for a man is an abnormal thing. So, and most guys remember back when they were in puberty. If you think back to then, if you don't feel like that now, you probably have a little bit of a low testosterone. So there are some other benefits though, in depressions associated with low testosterone, impaired cognition. A lot of guys say that their concentration's poor with low testosterone, and when we fix that or get their testosterone level up, that improves. And a lot of times they'll have improvement in their work function too, so their people at work will actually notice it. And osteoporosis obviously important as you get older, and that prevents that. So the prevalence, there's about 4 to 5 million guys in America that have low testosterone. We only treat a very small portion of those. So there's a lot of men walking around with low testosterone that don't realize they have it. They just think it's a normal thing of aging. And they're missing out on a lot of the benefits that they can if they were to get treated. So it's definitely something to discuss with your doctor. We were talking about some of the characteristics of testosterone. You can see what age does to you with the lack of testosterone. So this is a graph that kind of shows what happens as you age. I think that the Terminator would probably be about the middle of the graph in that picture, or maybe over towards the left-hand side, and you can see how his testosterone is going down. And then this is just kind of the opposite graph showing that testosterone, the prevalence as you get older. So you see that kind of the prime group is that 60 to 70-year-old male is when they really start seeing the difference. This is about testosterone prescription sales, and so when we start treating men for testosterone, or we've been treating guys with injections. I mean, you guys know this. You've probably heard of people being treated with injections for a long time. They've been around since the 1950s or 60s. But can anybody have a guess on why we saw this explosion in 1998, 1999? Does anybody know why you see that huge rise in the graph? Viagra, exactly. So it came out in 98, 99. We started direct-to-consumer marketing, And all of a sudden you have guys going to the doctor, right? Guys that would never have gone to the doctor before. So now we don't only see, if you'll remember this graph in a little bit when we talk about prostate cancer, you'll see the same graph on the diagnosis of prostate cancer, and it's all because of Viagra. So you see this huge spike in sales. And then the other thing that when you look at this is you see we typically had, this isn't something that you guys need to see, but this is just about a market overview of what the replacement therapy options are. You see a big growth based off of the prescriptions based off of a change in how they're delivered. So when we only had injections, we didn't get to, there weren't a whole lot of guys interested in doing injections. When you started doing topicals, yeah, go ahead.
So what do you think of the over-the-counter stuff?
The over-the-counter, like the stuff you get at GNC. So some of that stuff it's not actual testosterone. It's made to boost your testosterone. There's no data to support using it. So there's no randomized controlled data to show that it increases your testosterone over just exercise basically. So I wouldn't say that you're wasting your money, but you're probably not getting the benefit of it that you think you are. So same thing when we talk about BPH, we can talk about some of the natural remedies. One of the things, and I get this a lot, patients come and say, well, is it safe? My doctor said he doesn't want to prescribe it to me because I've had a heart attack, or my dad had a stroke and they don't want me to take it. They came out with a black box warning about testosterone because they were afraid, because it does increase your hematocrit, which is your blood count, and they were afraid that it would increase the risk of heart attack or stroke. And there was one study done at the VA that was a terribly contaminated study. And if anybody here has ever been or is part of the VA system, if you go there, you see a lot of guys that are at high risk for heart attack and stroke, mostly because of substance abuse issues. And they included those guys in this study. So what do you think happened? It showed that there was an increased risk of heart attack and stroke. So I personally have seen several patients that have had so much weight loss. I mean, they look like, if you go back to this, they look like if you just switch these. And you're talking about a kind of a 65-year-old guy that's overweight and unhealthy generally, and he gets buff. And he's exercising and he's out doing things and running, and I mean, it just totally changes their lives. Those guys are the guys that really benefit from testosterone the most, the ones that are really symptomatic from it to where they can't do anything. And I would make an argument that that guy is probably at a decreased risk for a heart attack and stroke now that he's on testosterone. So you just have to take every person as a different. So not everybody's the same. So who's appropriate? So if you guys come to me, somebody will call and say, I want to go in to see him to talk about this. Who's appropriate? So you have to be symptomatic. So if you just check your testosterone, and I see this a lot, I'll get a referral for somebody that's, doctor, just check their testosterone just to check it, and it's low, but the patient's got no symptoms. They have a normal sex drive. They have normal energy levels. They have no other symptoms. Then that's not somebody that we're going to treat. And so the the Endocrinology Society recommends less than 319. Most people kind of stick less than 300. So if you're less than 300 and you're symptomatic, then you would probably benefit from treatment or at least a trial of therapy. And we recommend against treating somebody just based solely off their number. And that's something that most doctors should know to treat the patient and not just the number. These are some of the different treatment options. Now you see the drug down here at the bottom left. This is probably the most common. It's testosterone cypionate. It's an injection. It's been around since the 50s. That's probably the most common, the easiest to dose. You see there's patches up there, there's creams, there's all kinds of stuff. There's a new injection out that's an injection that you get every 10 weeks rather than having to do it every week or two. There's a new nasal spray that came out this year, and that's been really popular, but you have to dose it twice a day. So if you want to give yourself a nasal spray twice a day, you can do that. You see the Testopel up there kind of in the center. That is a pellet that we put in under the skin, and you put it in about every 6 months, and that works very well for men. But if you look, the gels are probably the most commonly prescribed, and generally that's because primary care doctors feel very comfortable prescribing the gel. And so if you look at urologists, most urologists probably prescribe injections, which is the case in my practice. Because by the time I see most of these guys, they have already been seen by their primary care, they've already been on a gel, it didn't work, so they're coming to see me for another option. And I just tell everybody the injections are the easiest and the cheapest way to do it, and that's what we see. I mean, if you come see me, we're going to put you on probably one of the 3 injections, and you see the one at the bottom, the 3 milliliters every 10 weeks. That's becoming the most popular because guys don't like injecting themselves every 2 weeks. They forget. I mean, they don't remember that they haven't injected for a couple weeks, and they're now a month out and they're starting to feel sluggish again. So then they get this yo-yo effect. So the just scheduling them every 10 weeks in the office to do that's a really good option for them. So
what's the cottonseed oil it says?
That's just the suspension that it's in. So I put that up there because if some people say I'm allergic to cottonseed oil, well, we got to do something, or sesame oil. And the undeconate, I can't remember what suspension it is. I think it's cottonseed as well. So there's the Axiron was a new gel, Androgel that's down there on the bottom, even that you can kind of tell this slide, it may be a little bit old. Androgel is actually just went generic. So Axiron it's almost like a deodorant that you put on. And so that's a topical that goes under your arm. The big thing, the reason I try to get people away from gels, and it just depends on your stage of life. If you've got grandkids or if you've got small babies and stuff that you're holding, you're going to transfer that if you have a gel on. So that's another reason to stay away from it, and something that I counsel our patients on. The Testopel, this was really popular about 6 years ago until the Blue Cross of Alabama started giving us trouble paying for it, and just Blue Cross across the board. The benefit to it is it lasts so long, and some guys will actually get a year out of these things, so before they become hypogonadal again. And so it's 3 to 6 months is the average, but I've seen guys go 9 to 12 months with them. And it's a small, I tell everybody it's a small surgical procedure. It's not really surgery, but you do use a scalpel, just make a little nick in the skin and implant it under the skin. And it's all weight based off of your testosterone level and your weight, based off of how much we need to give you. So just to kind of conclude on testosterone, and we can stop and I can answer questions about this, but it's rapidly growing. Part of that's because our age gap is growing. The baby boomers are all aging. They all want to be younger. 70 is the new 40 or whatever they say now. So nobody wants to get old anymore. Nobody wants to do that. And there's going to be more controversies in the future as everybody ages on who's appropriate for treatment. But I see this as a booming market. If you look at the billions of dollars that are spent on healthcare every year, testosterone's in that group. So it's a big deal right now. Anybody got any questions about testosterone? You want to wait till the end? So moving on to prostate cancer, and this is something that girls can go to sleep on now, or you may want to just tell everybody, nudge your husband to stay awake. So prostate cancer is 29% of all cancers diagnosed in men in the U.S. So 1/3 of the guys that are diagnosed with cancer are diagnosed with prostate cancer. And you can see how that compares to breast. It's actually almost equivocal to breast. And so you see all this money put into breast cancer research, put into breast cancer prevention. We do a really bad job in America of prostate cancer prevention, and we've done a disservice to men because of that. If you look, the NFL recently, due to some people, including myself, who've been publicly shaming them for several years, everybody wears pink in October. and they don't do anything for prostate cancer awareness hardly. So now they've changed their thing to where it's not about breast cancer anymore. It's about the Intercept program, the Intercept Cancer, about early prevention of all cancers. So that's part of a shift of the NFL actually to shift away from and include prostate cancer as part of it. So it's the second leading cause of death in men. So if you get diagnosed with, if you die, you're gonna it's the second leading cause of death behind of cancer deaths rather behind lung cancer. So it's a big deal. People don't realize it. They say, oh, it's just prostate cancer. It's slow growing, but early detection saves lives. We know that. So this is a graph that's an interesting graph. So you guys that have a family history of prostate cancer, so you're at a much higher risk than somebody that doesn't. So my grandfather had prostate cancer, so I'm on that top line. Probably most of you guys have some form of family that's had prostate cancer and fall into that category. So it's something we used to say family history is a big predictor of death in prostate. Now we're learning that it's actually the genes that are associated with it. So that's the reason that the family line carries it. And so we're doing a lot more family testing now than we used to. So the traditional the traditional age that prostate cancer gets diagnosed in, and you can see this, and we'll talk about who should be screened for prostate cancer. You can see it kind of after you get over 75, it falls off. So if you're 75 years old, you've not been diagnosed, you probably are not going to die from prostate cancer. So it's really the group that we want to catch is that 55 to 75-year-old male. And that's what the national guidelines recommend now too, and we'll go over those in just a second. So this is the incidence of prostate cancer as it's changed over time. You can see prostate cancer up there at the top, lung is right below it in that red line. And we talked about this earlier about the spike. So why did the spike happen? Viagra, right? So guys didn't go to the doctor they went to their doctor to get Viagra, but they also got a PSA. They did a rectal exam on them to check them for prostate cancer. And lo and behold, they had prostate cancer. So we had this huge diagnosis, or a huge spike in diagnosis back in 98, 99. And that coincided with when we had the robot developed and came out for robotic prostatectomy. So we had a lot of treatment started happening for prostate cancer. And then after that, we saw a big shift away from guys dying from prostate cancer because their prostate cancer was detected early. They were detected by Viagra. So there's a lot of guys that owe Viagra. They can say Viagra saved their life because of that. So what happened this is the death rate from prostate cancer. You can see lung on the top, that's the highest risk of cancer death in men. Prostate down there on that second slope, but you can see it start going down after Viagra came out. So the people that argue that early detection of prostate cancer doesn't save lives just need to see this graph and just look at the numbers. The numbers don't lie. So we talk about guys got checked by their physician with PSA. So has everybody in here had a PSA? Almost everybody probably. You wouldn't be coming to a health talk if you didn't. The guy I need to be talking to is down the street, you know. But a lot of people don't know what PSA, why we check PSA or what it does. So PSA, it's just a protein. It's actually the purpose of PSA. It's found only in prostate tissue, and it's to liquefy semen, to make the semen easier to swim. So, small amounts of it get detected in the blood. They discovered this back in the 80s that they could check men that had prostate cancer with PSA, and it actually was a really good tumor marker. So we started checking it on everybody. And then we didn't really know what we were doing with it. We just knew that it was abnormal. Then what would you do? We'd biopsy you. And so now we took a step back a couple of years ago to say, well, we don't need to check everybody because that's leading to us treating, we have somebody that comes in that's 85 that has an elevated PSA. Well, they also have an enlarged prostate, right? So a bigger prostate is going to make more PSA. So now we have somebody coming in that we don't know what to do with them because we don't want to tell them they don't have cancer. We don't want to treat them if they don't need it. And so they came out with these guidelines to recommend on who to check PSA in. They're probably not inclusive enough. I think that the AUA, that's the American Urology Association, probably took too far of a step back. And we need to be including men that are younger. What I typically do, and this is kind of my algorithm in my office, is if you have somebody that died from prostate cancer, you get a PSA at 40 to 45, depending on your ethnicity. African American, we always start at 40. At least get 1 to see what it is. If it's normal, if it's less than 1, it's really low risk, then we can maybe check it in 5 years. But again, it goes back to just like testosterone, you have to treat the patient. And sometimes, if you come into the office and you're 80 years old dragging an oxygen tank, I'm going to tell you don't worry about it. If you come into the office and you're running a marathon, just did a marathon, you're 82, I have a patient like that, then we're probably going to continue to check your PSA because you would still benefit from the screening. So, I generally just recommend only annual screening between the ages of 55 and 75. And that goes back to that graph where it shows that that's where the bulk of those people that we're trying to catch are. So, and we just continue to screen you based off your health. Like I said, you make it to 80. I had a patient say, well, we don't need to check it anymore. And he's like, why? I still feel fine. I'm still healthy. I said, well, we continue to check it until you develop some health problems. So, and it's ultimately your choice. And and what I tell everybody is knowledge is power. If you have an elevated PSA, it doesn't mean you have to have cancer or have to do anything, but at least you can follow it. So we've got a lot of new tools out too. This is a common thing on why people say, well, they told me my PSA is elevated, but they didn't tell me why. And so there's a couple of things that will drive PSA up, and cancer is the reason that you always make it into my office to find out. But trauma to the prostate, and usually we see this with somebody who recently had a catheter. We get a lot of consults in the hospital. Somebody will get admitted. The intern that sees the patient thinks they're doing a great job and doing everything comprehensively, and they'll order a PSA on somebody that had a catheter put in when they came into the hospital, and then their PSA's up, and we have to go in and say, hey, that's normal because your prostate was traumatized. Infection of the prostate, and those are symptomatic infections. And then, like I said earlier, just an enlarged prostate. So somebody with an enlarged prostate, it's going to make more PSA. So if you got more tissue, you're going to make more PSA, and it's going to drive your PSA up. So, and then we'll talk a little bit about what we can do for BPH in a little bit too. But it used to be that everybody was afraid to check the PSA because they were afraid that we would biopsy everybody. Don't check my PSA, they're going to send me for a biopsy, and my buddy Ralph hated that, and I don't want to have to do that. So there's a lot of new stuff coming out. So there's 3 new blood tests that have come out in the past 5 years for PSA to estimate the risk of cancer by the PSA being elevated. So the newest thing that's come out is MRI. So this is the hottest topic for prostate right now. You can see this graph at the bottom. That's where we're doing targeted biopsies using a patient's MRI. The MRI, you have to have a special MRI to do this. We have one at South. We were the first one on the Gulf Coast to have this MRI to do this. And it has a really strong magnet in it, and it will help illuminate patients that have clinically significant prostate cancer. So patients that have that are at high risk for it spreading, it will show up. And what we do is there's a special piece of equipment we call UroNav that will allow us to target those biopsies rather than the typical biopsy that you usually get when you're that your buddy may have had. We usually will do these with MRI guidance, and so it's not. Is that the tornado thing? Okay, that's kind of disheartening. But yeah, so these things. So we're moving away from collecting just tons of tissue on patients in an effort to try to screen them for prostate cancer, and we're using imaging to do it. So it's really taken, for a lot of guys, it's taken the fear of checking their PSA out, because there's a lot of guys that just don't want their PSA checked because they don't want to have to go through that. Like, I don't want to have to do that if my buddy had it. I'd rather just not know. And that's the ostrich, sticking its head in the sand. And so now, they're doing this in Europe, and I see us doing this probably in the next couple of years. So everybody's going to now get a PSA again, And if it's abnormal, then they get an MRI. If that's normal, then you don't do anything. And you'll only end up getting a biopsy if your MRI is abnormal. So we're headed there. The other reason that guys don't want their PSA checked is because they don't know what their treatment options are for prostate cancer. And they remember their friend or their dad or somebody who had it, and he was in diapers and was debilitated by it. And so what I tell people, and this is just a take-home slide. I'm not going to go into all of the options for prostate cancer, but we've done a bad job as urologists and oncologists and just kind of create a nightmare for patients to try to choose what they want for prostate cancer. Since 1982, I think, we've had 8 different treatment options come available, and none of them have any evidence to support one or the other over surgery or radiation. The only 2 that we really talk about. So we've been playing catch up for the past 10 years, trying to develop a protocol and trying to go back and look at the patients that have been treated with one option or the other and compare them. But what I can tell you, and this is my little plug for robotics, is the surgery we do now for prostate cancer is not the same surgery my grandfather had in '98. It's a completely different experience for patients. It's an outpatient procedure now. It's virtually, I say virtually because of the cocktail of medications that we give patients, but it's almost a painless procedure. And you still have to have a catheter, which everybody hates for a week, and there's not anybody that's ever wanted to keep one in. But it's a much different procedure. It's curative for patients, and it has been proven to extend life expectancy and keep you cancer free. So if you talk to somebody that's trying to go down this route of deciding, have them go see somebody that does a lot of robotic surgery, that does a lot of robotic prostatectomy, and get a good outcome. And you talk to those patients and they're like, man, I'm so glad that I did that rather than choosing something else, because they're virtually normal afterwards. So we're playing catch up now, trying to prove that that's the best way to do it. The 30-year data on surgery shows that that's the best way. And the second option is radiation, and all the other 6 are starting to play out that they're inferior. And I can spend an hour talking about all the different treatment options for prostate cancer, but just know that it's just much different. Don't be afraid to get your PSA checked because of the fear of treatment. So.
Now you do that laparoscopic?
Laparoscopic, yeah. So the robot is essentially just a laparoscopic sewing machine. I mean, that's all it is. And so it's just I did one this morning, and an hour and a half, guy will go home first thing in the morning. And so, and if he didn't have the insurance he had, I'd send him home today. But they won't pay for it unless he stays in the hospital one day. So, yeah. So now we're trying to move to doing it outpatient to where we just send him home. Versus my grandfather, I keep using my grandfather as an example. He was in Vanderbilt for a week and a half, I think, 3 or 4 units of blood. So, and we don't have those outcomes anymore. So, and he had a good outcome at the time. That was an expected thing. So, moving over into BPH. So BPH is benign prostate hypertrophy. Okay, so this is non-cancerous. These are guys that just have a prostate that's getting enlarged, like probably 80% of the guys in this room have, because you're in the age group. But you're starting to have symptoms, and the prostate's just getting enlarged to where you're having problems with it. And we see a lot of guys come see me because of their BPH, and then we find out that they have an elevated PSA, and then we either get an MRI or something on them to help discern that, and we find out they got prostate cancer. And so they can have both. And so it's an important thing to consider. And a lot of people come to us thinking they have prostate cancer because they have these symptoms. But in actuality, most men don't have prostate cancer that have these symptoms. So, but if you look at it, it's the 4th diagnosis in men, 50 years or older. So it's the 4th leading diagnosis in men. Coronary artery disease, hypertension, diabetes in America. Now, if you go outside of America, you'll see enlarged prostate jump up to the top of that list, probably to number 2, depending on which country you look in, because they don't have as much of an obesity problem. You go to France, this will come to the top of the list. They don't have obesity and hypertension and diabetes that go with it. So, and if you look on here, just to get on my high horse about obesity, coronary artery disease, number 1, hypertension, number 2, diabetes, number 3, osteoarthritis, number 5, so that's arthritis. Those are probably all related to our obesity epidemic that we have in America. So if you got rid of the obesity in America, you'd probably remove the top 4 diagnoses. So something to think about. So a normal prostate, just to give you a little overview of the anatomy. So you have the bladder above it. Why God put the urethra going through the prostate, which is an organ that enlarges from day one, I don't know. That's going to be one of the first things I ask him when I get to heaven. So, I mean, it just baffles me. But I'm sure, I mean, God's sovereignty, we know that there's a reason. But as the prostate gets large, it chokes off the tube. It's like stepping on a water hose that you're trying to get water to come through. And then you stand there and you try to wait, and you go, and then you got to go a little bit more, and it dribbles out. And you see the changes on the right side of the screen from the bladder. And so that's what happens is the bladder is a muscle. It's just like your bicep. I don't have a big one because I don't lift a lot of weight. But if I lifted weights, my bicep would get a lot bigger. Just like the muscle in the bladder, if you work it harder over time, it will thicken and thicken and thicken. And what happens with a lot of guys is they get these bladders that are thick, and I tell them it's kind of like a football. When you fill the football full, if you're not a Patriots fan, you'll understand this. But if you fill the football full, it's full. There's no expansion. It's not like a balloon, it just gets full. And that's what will happen with your bladder when it gets thickened like that. So a lot of guys will come and say, I don't have a problem going to the bathroom, but when I need to go, I need to go. And that's because they don't think they have a problem. It's been going on and growing like this since they turned 14 and hit puberty and started producing testosterone, which is what causes your prostate to grow. So by the time they're 65 years old, they've got this bladder that looks like the one on the right. And so then we have to kind of try to undo things. But you can, that's a very good illustration of kind of what things look like. And a lot of times we'll scope people and to show them what's going on inside their bladder. We do something called cystoscopy, and the bladder looks just like that on the right. So if you guys ever come into my office, if I see one of you guys and we scope you, just remember that picture, and we'll look at it on the screen, and I can show you what your bladder looks like. So the prevalence as you age, though, this is kind of a graph, and it shows the prime target area for these patients are between 65, 75 years of age, kind of where prostate cancer is, right? So the middle of the curve for prostate cancer is in the same spot, which is the reason I tell people, look, if you got gray hair or you're over 50, you need to know who your urologist is. So, I mean, if you don't think you need a urologist, if you don't think you need a doctor, you at least need a urologist when you get that age. To make sure that this stuff's not happening to you. What we worry the most about, and I'm going to put the symptoms up while you look at this, but what we worry the most about is that your bladder gives up, because that will happen over time. So if you ask the bladder to try to push urine through a prostate that is too hard to push urine through, it will eventually just say, I'm done. I'm not going to do this anymore. And then we're really up the creek, because we're seeing you with a catheter in because you had to come into the ER, you had 3 liters of urine in your bladder, or you had kidney failure or something like that, and it's much harder to treat you when you're in that position. But I won't ask anybody in the room about these symptoms, but I bet I can look out there and see about almost everybody's gonna have 2 of them, right? So, and if you really have any of them, you really need to see somebody to get it evaluated to make sure that you are emptying. And so the frequent urination happens because you can't empty all the way. So your bucket's always half full. And so you go to the bathroom and you empty, and you get the bucket half empty, and then you got to go back again, right? So you go frequently. Multiple trips to the bathroom at night, same reason. A lot of times guys have sleep apnea, though, that contributes to this and masks the symptoms of their prostate. They think it's either sleep apnea, so they don't come see us, or vice versa. They come see me and I say, you got sleep apnea, you don't have anything wrong with your prostate. Just go get your sleep apnea treated and you're fine. In fact, I see probably one guy a month that we take him off his prostate meds. He's been on it for 10 years and it hasn't worked. And finally he comes to see us, and they say, and I say, no, it's just your sleep apnea that's causing the problem. So, yeah. Difficult or painful urination. So this is one thing when I talk to emergency room residents, we teach the residents and I give them lectures on urology. Difficult or painful urination. So painful urination is an abnormal sign in anyone, okay? And it should always be worked up in a man, okay? So if in a urinary tract, because it's usually indicative of a urinary tract infection, if you've had a urinary tract infection and you've seen your primary care doctor and they wrote you an antibiotic and did not refer you to a urologist, you need to ask them to refer you to a urologist. So that's an abnormal finding anytime in a man. And so we tell the ER residents that because a lot of times they'll say, oh yeah, you got a urinary tract infection, they write them an antibiotic and send them home. And so we tell them, look, you're okay to write them an antibiotic, doing the right thing by treating them, but make sure that they get followed up by a urologist because that's abnormal in a man. A female, we know females get 3 urinary tract infections a year is actually considered normal. So seems like it shouldn't be, but that's how often they get them. Well, there's a lot of bladder irritants, so that contributes to a lot of this. And the bladder, so your bladder's kind of primed. If you have BPH, your bladder's kind of primed. It's already irritated, right? And so because it's having to work too hard. And then you throw in coffee, artificial sweeteners, red dye. A lot of people don't realize that. Red dye, like red Gatorade, has red 40 in it. That will irritate the bladder. Caffeine is a big thing in coffee, but coffee has other irritants too. So even, and this is good for females in the room too, even decaf coffee's got a lot of oxalate in it, and the acid that you see in Cokes and things like that will irritate the bladder. So yes, there's the urge to urinate and the frequency to urinate is definitely associated with bladder irritants. But your bladder's kind of primed when you have an enlarged prostate, and it's got a hair trigger basically. Some guys complain of incomplete emptying, and that kind of goes with I never feel like I get all the way empty. I go to the bathroom and then I feel like I can't get it all the way out, or I have to strain. And the starting and stopping, that's kind of indicative of something we call a median lobe. You can have that and just have pure, plain, normal BPH, but there is a type of BPH where it grows on the back part of your gland, and it will act like if anybody knows what a flapper valve in the toilet looks like, that happens in the bladder, and that gland will shut, and they'll just all of a sudden stop. And those guys are very symptomatic from that. They'll come in, and that's their chief complaint. Is it's just. I had a patient one time that told me, he was a VA patient. He said, I can't write in cursive. All I can do is Morse code. And I thought that was probably the best analogy. And I knew exactly what he meant when he said it. And we had to do a scope to make sure, but sure enough, he had a big median lobe. So when we look at how guys are treated, a lot of guys are watchful waiting. So we just kind of monitor them. It just depends on the severity of their symptoms. If they're not all that bad, we just kind of make sure that they're emptying all the way. And if we see that starts to not happen, or they start having really bad problems with sleep, then we'll intervene. Most guys will choose drugs over anything. I think that's probably the case for most guys in any specialty. If there's a drug, you're going to choose that over surgery or a procedure. But there's an alarming amount of guys that we put on these medications that either the drug doesn't work, or they come off of it because of really bad side effects. And some of them are bad side effects because they get dizzy and they fall. Some of them are just sexual side effects that they don't like. And a lot of guys will start it and they'll come back and just like a typical guy, oh yeah, I'm good now. And they don't tell us any different. And so we kind of continue to follow them just to make sure, because guys are a really hard population to take care of. I don't know if you guys know that, but they're stubborn. They won't tell you the truth. So we have all these little tricks that we have to get the truth out of them. So, but only 3% of guys will choose a surgical procedure, which that's actually the best treatment for this. And I'm not trying to talk anybody into surgery today, but it really is one of the best treatments for it, and it's been around forever. So 65% of the patients are open to considering it, and so it's really just how we ask the patients. So If you look, this is kind of that same picture that we were looking at earlier, and you see the prostate getting larger and larger and squeezing on the urethra, the tube that runs through there, and that's actually us looking in the bladder on the bottom, and you can see what that looks like from normal to abnormal, and then this is another picture that we talked about earlier, as far as what normal looks like, and then the obstructed view as the bladder and the prostate gets larger and the bladder gets thicker. There's a really neat procedure that just came out, and I'll show you this video in just a second, but you're limited to a couple of different options. You're either limited to this option surgically if the medications don't work, or you can go in and remove tissue. And a lot of you guys will know people that had a TURP, which was an old school way of doing it. And we still do those. It works very well. That's what almost all of our stuff is compared to, but it has a higher risk for bleeding and it has a higher risk for sexual dysfunction. There's a new thing out called the green light laser. I quit doing those a few years ago because the outcomes on them, they don't last much longer than 3 to 5 years, the symptom relief. And so I started doing something called a holmium laser enucleation or a thulium laser enucleation, which removes almost all the tissue. So there's a lot of surgical options, and they're all outpatient. They're all, and this one, in fact, we do in the office. So I think if this will work, I don't know if this will work or not. You can see how this is actually a suture that we put through, and it anchors on the outside of the prostate like a toggle bolt, and then you stretch the prostate urethra open, put another one on each side, and we end up doing this usually about 4 times. And the guy can do this under just local anesthesia there in the office. It takes about 4 minutes to do it, and it has a huge symptom relief. So that's before and after. I don't know if that's a picture that I did or somebody else did, but that was before and after. It's a pretty neat procedure, and this is a good option for people. It's called UroLift, but it's a good option for people that are on a medication that aren't either happy with it or it's getting to where it doesn't work. And there's some stipulations on who can have that. You got to be really you have to have the perfect anatomy in order to do it. So that's the end of my talk. I'll be happy to answer any questions that anybody has. I finished a little bit early. I've never heard anybody complain about that, though. So, do you guys have any questions about urology in general?
The BPH, the last topic you talked about, please give us some of the medication options.
So the tried and true is Flomax. That's tamsulosin. That's what most people will start you on. The reason is because it's cheap and it's generic and it's been around forever. There's several different derivations of that. One of those is doxazosin, which is an older version, and the other one's sildosin, which is Rapaflo. Those are all generic now. There's not a new medication that's out in that class. That medication is usually the frontline therapy, and probably if anybody in here has ever been put on anything, that Flomax is usually the first thing they put you on. There's another class of medications called 5-alpha reductase inhibitors, or finasteride or dutasteride. Those are the Avodart's, the other one. Those medicines shrink the prostate, and so those medicines take about 2 years to work. So typically, if you don't have and you'll get a better response out of both of those medicines together, but typically by the time I've seen somebody, they're either on one or both of them and they're not working. And so if the Flomax does not work well for people, I usually don't put them on the additional medication, because it's going to take 2 years to figure out if that's going to work. And by the time they see me, they've already seen their primary care doctor. He's already put them on 2 or 3 medications. Neither one of them are working. They want something done. But that's usually the way that I'll start it. So if I'm seeing somebody that's fresh, never been on anything, I'll start them on Flomax. If they have a good response, then we'll combine it and do combined therapy and keep them on that. And some guys do great on just the medicines alone. I'd say it's probably 50% of the guys that we see that need treatment will do well with medicine. So And those medicines have only been out since the 83 is when Flomax came out, so, or doxazosine came out. Yes, sir.
On one of the previous slides, you showed 3 prostates, and you had the small one, and then, or the normal one, and the large one. And then, yes, what is happening in the one on the extreme right?
So that is, so that's prostate adenoma. That's the BPH. That's the benign stuff. And what's interesting, I always tell this to med students too. If you took that prostate tissue out and you sent it to the pathologist and didn't give them a patient's name, they couldn't tell if that was an adenoma from the uterus or the prostate. So it's the same thing that women get fibroids. It's the same type of tissue. It's just a benign tissue, and it continues to grow. And so some men have a problem with it, some of them don't. But that's just a diagram that shows like the normal prostate tissue being replaced by that adenoma. And
That would be an extreme situation with your prostate.
yeah, that would be an extreme case of it. So, but yeah, I would say most people kind of look like this on the left or in the center where they've got a little bit of a restriction. But yeah, you see some guys that have big adenomas. I mean, just huge. So size of a softball, something like that sometimes. That's just the tissue. That's the type of tissue. It's a benign tumor if you want to think about it like that. Technically, that's what it is. But you tell people they got a tumor in their prostate, they think they got prostate cancer. So we just say it's BPH. But it's a benign tumor growing in the prostate, around the urethra. Who knows why that happened? But somebody else had their hand up. Yeah.
I didn't quite catch the connection. That's the causational, correlational between high PSA and BPH.
High PSA and BPH.
Right.
What was the question?
I didn't quite catch. Is there a correlation? Is it causational?
It's causational, yeah. So BPH, so as it gets larger, it's producing more PSA. And so when it's producing more PSA, I mean, just because of the size of it, it's a volume. And you can take the size of the prostate and index it to the PSA. And actually, if it's less than 15%, that's a good sign that it's from an enlarged prostate and not from prostate cancer. So yeah, yep. Yes, sir.
How does lack of sex affect your prostate?
So lack of ejaculation has actually been shown, so guys that are not very sexually active has been shown to increase their risk of prostate cancer. So it doesn't change anything from BPH, but it does increase your risk for prostate cancer. We think that that's because the semen and the things that are produced in the prostate that just sit in there will cause, you get those toxins in all of your body fluid that just sit inside one place, and it puts you at risk for it. So that's been proven in a couple of studies, but we don't quite understand the link between it. So that's the same, BPH is actually associated with a higher risk for bladder cancer, and we think it's the same reason because the urine doesn't empty well, so the toxins that are in the urine, everything we ingest gets either excreted through our stool or our urine. And so if we take in a toxin, that's going to go through the urine as well. So that's associated with BPH as well.
How can you tell if your bladder is emptying properly?
The correct answer to that is you can't. So if you have the symptom that you feel like you can't, then you may not be. The way that we tell in the office is we do an ultrasound on you just to make sure that the bladder's empty. So. But yeah, so. Yes, ma'am? Yeah, go ahead.
Okay, I'm a little confused. So if you have a high PSA,
Mm-hmm.
do you go to a biopsy first or the MRI first?
Right now in America, it depends on your insurance status. I would prefer to go to an MRI first. That's what the Europeans are doing right now. They're a little bit ahead of us. It depends on, if you got Blue Cross Alabama, we got to do a biopsy first. They won't let us do an MRI. If you got Medicare, I can do an MRI first.
Okay, and the MRI first is just to not traumatize the...
Yeah, so what I tell people is we could go, I can drive from here to Destin with no problem, right? So, or I can put it in my GPS and go exactly where I want to go. And so the MRI helps us direct our biopsies. Eventually, our guidelines still require a 12 core biopsy, but eventually that's going to go away, and all we're going to do is just do a one or 2 core biopsy of the prostate, which reduces the risk of bleeding, et cetera. So, I think probably we're about 3 years from where we can just get an MRI on everybody, but that's where we're headed. So, yeah. Yes, sir.
PSA test, is that more preferred than a physical?
They're both actually needed. So you need both of them, not just PSA. So some high-risk prostate cancers don't produce a lot of PSA. So some of them just by virtue, just because they've lost the genetic ability to do it. And you can have really high-risk prostate cancer that has a low PSA. So that's the reason it's important to get both. Yep. All right, thank you guys.